Hi everyone, let's discuss a multilevel canal stenosis and its treatment by biportal endoscopic spine surgery. You can see L34, 45 and 5S1 are completely stenosed with very narrow canal diameter. With is degenerative scoliosis at L45 level and severe stenosis at the other level like that is L34 and L5S1. The CT pre-op CT scan and the axial scans of the MRI, you can see the 434 is completely stenosed. Here in the CT scan also you can see the orientation of the spine. Now we started the procedure by moving to the fusion first, which is at L45 level with decompression at L5S1 and L34 level. So this is the 4-5 level. We are removing the ligamentum flavum slowly because in very severe canal stenosis the ligamentum flavum is somewhere attached to the dura and dura is very thinned out, so you have to carefully remove the ligamentum flavum. I have also done the decompression from same ports and extended it to the L5S1 level. This is the contralateral facet I am working on. You can see the mighty hypertrophied facet on bilateral side, and careful trimming of the facet with a osteotome is paramount importance in making the canal wider. Osteotomes are very handy in biportal endoscopic spine surgery and can be easily introduced to the working port. So we are working now on the contralateral SAP, which is visible, and you can appreciate how thinned out the cord is because of severe canal stenosis. So this is the pedicular area and disc area of L45, and you can see I have well extended the decompression to 5S1 also. This is the disc level. The fibers of the annulus are visible and the root is also the traversing root is also identified. Because the facets are hypertrophied, so I am trying to remove the medial border of the SAP to make the traversing route more evident. You can see a lot of bony work has been done to shape the canal. The contralateral disc and the contralateral tip of the SAP is excised to make the foramen wider, and this can be very well done with unilateral biportal endoscopy because of its versatility of the procedure. There are a lot of bony hypertrophy which are chiseled down to increase the diameter of the canal. Now we started using the radiofrequency probe to clean out the area of the annulotomy so that we can put our instrumentations. So now a wide area has been created lateral to the cord bilaterally, so that whenever we retract the roots to put the cage, pressure does not transfer to the neural structures. Almost the medial border of the SAP has been excised. The contralateral disc and the ipsilateral disc are well visible. Radio frequency probe is very handy in biportal endoscopy for soft tissue clearing, making the area more visually augmented. So we can very well clearly identify the disc space here. Now Indian knife going in, making the first annulotomy. Then it was the RF radio frequency ablation setting. Tried to make the annulotomy wider. Before doing the annulotomy, we always use coagulation to shrink the vessels. Then we move to the ablation settings for making the hole in the annulus or annulotomy. Now then we start going inside the disc space and expand the area so that we make a wonderful disc space preparation. You can see the roots are free but somehow little bulged. So we moved in and did the end plate preparation with the dissector. After putting the cage at L4-5 level, we move to the L3-4 level, and now you can see we have decompressed the L3-4 level well with excision of ligamentum flavum. Now you can see, well seen, I have removed the lamina of the L3, and you can see inside from here the L4-5 level, which is well decompressed. So we have finally done a fusion at L4-5 with a decompression at L3-4 and L5-S1 level. Now you can see the final 3D recon of the post-op CT scan. You can see at 3-4-5 I have done a fusion, and you can see 3-4, 4-5, 5-S1 all hemilaminectomy has been done and connected. This is only possible with a this diverse endoscopic way, which is unilateral biportal endoscopy. Thank you so much. So you can see how unilateral laminectomy has been done for this patient. From here to here, all laminectomy had done by biportal endoscopy. You see, decompression has been done in multiple levels, completely by biportal endoscopy.